Yes, so welcome to another edition of the Cameroon Town Hall. And today, of course, we are going to have another very exciting discussion. Hopefully, it's always, I don't think hopefully is the word because every session in the town hall is just so special. And we are always thrilled to have, wonderful presentations. And I think it's not going to be any different today. And today we'll be talking about cancers and about bridging the gap, the care gap. I think we've entitled it World Cancer Day, of course, Bridging Cancer Care Disparities in Cameroon. So, and obviously there was no other person well qualified. I think there are many qualified people, but I think there was no other person passionate, about this topic enough. We know he's qualified than our very own chair, Dr. Munoh Kenne Foma of the Cameroon Town Hall for Healthcare Practitioners. And so that is the discussion that we would be having today with Munoh. And I know it's going to be a really exciting discussion. But before we come back to Munoh, I would just want to get on to Elvis first, and then probably to Brian as well, who are the other moderators on this particular call tonight, just to hear their thoughts around this particular topic.
Hi, Dr. Kate. Thank you. And it's nice to be here once again. Good afternoon and good evening to all fervent participants of the Cameroon Town Hall. It's really going to be an exciting session, especially when we have our own trusted authority in this domain, Dr. Munoh. So one will expect to really take some notes here today. And we all understand that cancer, kills nearly 10 million people globally. So it's really a serious public health issue. And in Africa, the cancer care gap presents significant challenges, especially with limited resources and capacity to control cancer. And we all know that the number of cancer treatment centers in sub-Saharan Africa is insufficient to meet the increasing needs of the population affected by cancer. So there are also economic constraints and infrastructure constraints, but now Munoh will be telling us about the situation in Cameroon and how we can bridge the cancer care gap in Cameroon. But I think it's really going to be an exciting topic. I've had a lot of friends who have lost their loved ones to cancer recently, so it's really a topic that is really close to home, and I'm sure that all of us are going to really be excited to learn and share a lot on this topic today. Thank you very much, Dr. Kate.
Thank you very much, Elvis. I've not seen Brian yet, but I know Brian is there. Okay.
He's there.
All right.
Yeah, thanks, Kathy, and thanks a lot for your introduction, and also thanks, Elvis. It's always great to be back here. I think a few weeks ago, I think early in February, the international community was commemorating the World Cancer Day, and I took some time to read a little bit more about the history of World Cancer Day and how it was established and where it was established and why it was established. I was a little bit disappointed that it was only recently in the early 2000s that it was recognized as a significant challenge. I think Cameroon and Cameroon, just like other African countries, are experiencing this pivotal moment in the oncology landscape where we are seeing a rapid shift in the dynamics of infectious disease burden and non-communicable disease burden, particularly driven by cancers. And we have a very we have a major problem because that's a huge deficit of healthcare workers. We have a huge deficit of diagnostic challenges. We have limited access to treatments. Therapeutic cost is enormous. Most families in our context cannot afford this. So I'm really thrilled that Dr. Munoh is taking on this subject to talk about it, and I'm really looking forward to his remarks. But more in particular, how how the things that he's learned in throughout his career as an oncologist can be useful and leveraged to help bridge the cancer gap in Cameroon. So I'm really looking forward to the to his remarks today. So thank you, Elvis, and over to you, Kathy.
Yeah, thank you so much, Brian. I think without much ado, because we can talk heavily about the burden that's the epidemiological landscape of cancers and other non-communicable diseases. And obviously, we would come to realize that there's so much to be done. I don't think Munoh needs any formal introduction to the town hall. We know who he is. And so I'm just going to quickly hand over to Munoh for this very first phase of the presentation that we are going to have, and then we are going to gradually move into Q&A or into the Q&A session. So over to you, Munoh.
Well, thank you very much, Dr. Kathy and Elvis and Brian for introducing this session, which I think it's something I'm passionate about. But just a little before I start, there'll be a lot of people here questioning why am I doing this presentation? I've seen a lot of people who are here for the first time. So who is Munoh? I'm going to do it in few sentences. I am a former graduate of the Faculty of Medicine. So I did my medical education in Cameroon, so I know the Cameroonian landscape very well. Also, I did a residency in clinical pathology, so I do know the laboratory landscape very well in Cameroon before ever moving to the US. And I'm an avid supporter of public health, despite being a clinician. So I did a master's in public health, then did internal medicine in the US for 3 years. And I also did a specialty in hematology and oncology. In the US is joined, which I did my fellowship at Richmond University and Presbyterian Cornell. So I've been doing medicine for over 20 years. Schooling, let me put it this way. And my real passion is trying to see how we can bridge the gap and get to understand each other, really, when it comes to healthcare and diseases, really. So a lot of people will think, why did we even start the town hall in the first place? I think the goal for the town hall with all the moderators here was just to get to bridge the gap between COVID, what was happening in New York City, and what we thought was going to happen in Africa, which, thank God, we never had that. So today I will spend time to really try to, for us to discuss. I've been traumatized in the past 3 years by the number of cases I've had and calls I've had from Cameroon. So when you talk about cancer care, what are the pillars of cancer care? It's very important that you cannot really cure cancer or treat cancer patients. I do see about 100 cancer patients every week in my practice, 100. So I have a lot of experience when it comes to about 20 every day, some days 25, and for 5 days a week. And weekends, which I'm on call, I get to see more than 200 patients. So in the pillar, when we talk about cancer care, what is very important is that you need to have a strong surgical department. But surgery alone, for more than 200 years, we've been using surgery to cure cancer, but we recently realized that surgery alone is not enough. And this is where some of the weaknesses is coming. We do have good general surgical care in Cameroon, but we do lack subspecialty cares which can help us in the treatment of cancer. You need a radiation oncology department for radiotherapy. The problem in Cameroon, these are technologies that have existed since the 18th century, is that presently we have just about 3 to 4 working radiation therapy centers, which one only works constantly, which is in the private sector. And the technology is actually very archaic, except for the one that is existing. And we need to upgrade that department, not only with physicians, but with physicists, with dosimetrists. So this is something which we don't really think about. Traditional chemotherapy has been there since the 40s, but we're still unable to give chemotherapy in a precise and sustained way where people will not die from it. I can recall one of my aunts who passed away told me she was afraid to go to l'Hôpital General just because she thought that she was going to die from the chemo itself. Precision medicine has been existing and has been existing since 1998, but availability is a problem back home. Each week, I think I get about 20 WhatsApp messages. I don't reply to all of them. Unfortunately, I'm sorry about that. I just cannot sustain replying to all. But each person telling me about their personal problems, different cancers in their families, and you have to try to figure out what the right thing to do. You do have immunotherapy, which has been available since 1997. But its accessibility in Africa and Cameroon is totally mind-blowing that we don't even have it available. You cannot have a good oncology department without getting a good pathology department. I happen to be one of those who is talking here. I know the landscape of pathology in Cameroon because I worked in Cameroon as a clinical pathologist, and you can see that the availability and the diagnosis, we still lack basics in doing immunohistochemistry. Only one lab in Cameroon is able to do immunohistochemistry, and they export it outside, the Central Pasteur. How will those who live in the Northwest do? Those in the Southwest, those who are in the North, though there is a Central Pasteur in Garoua. So you get to see that training it's a big problem. Surgical department, I have a case which we just recently discussed, a little girl who is 23 years old and she has a squamous cell cancer. She needs surgery. Do we have an adequate cardiovascular department that can take out that lump and actually treat her? Are we going to be able to stage it appropriately? These are all things that really have to call for our reflection. I know in Africa we have multiple health problems. The burden of disease and infectious disease is tremendous. We also need a strong radiology department. It's not just about training radiation doctors with radiology, but you need to precisely train them on how to read cancer imaging. You need to train the primary care doctors on understanding the basic tenets of oncology in staging patients. People need to understand that you have to, where there is no tissue, there is no issue. You cannot treat a cancer without tissue. So pathology becomes the cornerstone of every oncology department that is going to develop. Radiology is also one of the pillars, which is not included here. And you do have other pillars. You cannot come into a country and institute radiation oncology without having physicists, without having dosimetrists. And you cannot proliferate medical schools alone without taking care of subspecialty nursing. These are all things that we need to reflect about while we are going to tackle cancer going forward in Africa. Cancer is one of those diseases that shows the weakness of every healthcare system. Even in the US where I stay, if you want to know how weak a state's healthcare system is, you can understand how much they can take care of cancer patients. This is an example which the gynecologists are going to be familiar with, where we're talking about cervical cancer. I just want to show you how much it takes. A lot of people would think there are very few cervical cancers that actually do need surgical care. Majority of the time, they are too advanced that surgery is not going to help them. So we need to properly diagnose them. We need good imaging. We need multidisciplinary teams. We need med oncologists. We need gyn oncologists who are trained gyn oncologists, not just because they have experience. We need clinical oncologists. We need pathologists. We need pharmacists. We need a lot of these people who are going to help us in order for us to be able to. We need radiologists. We need everyone on board that would help us for us to be able to treat and take care of these patients. If you don't have this, you will not be able to take care of cervical cancer. Why I took cervical cancer is one of the cancers you can eliminate. I can assure you, where I work, if there is any patient who comes in with cervical cancer, most of the time, they are from the very poor part of the state. 2, their knowledge gap compared to the average knowledge gap of the American is very high. 3, they are immigrants. Why? Because cervical cancer can be eliminated totally. Australia has shown us, Netherlands have shown us, New Zealand has done so, and the US is trying to do so, though they're still having an issue. Now, my case today, I decided to do it in a different way so that you guys get to see what I see as an oncologist every day. Why did I do it this way? These are all cases. I've had over, I think, more than 100 cases. I do tumor boards with the Bamenda Regional Hospital, which I'm not going to include, and bingo, but I'm not going to include those cases here. These are cases I was called for, either for advice by a family member or someone. And I want to present how difficult the knowledge gap and the availability of treatment is in Cameroon. So this is a 40-year-old patient who got diagnosed in Cameroon. She was diagnosed initially with cervical cancer. She got a hysterectomy. Staging workup was not done. And her sisters got very concerned about her situation after hysterectomy. And actually, fortunately, she came to the US. We did a staging workup. She already had metastatic disease with liver metastasis. And she ended up getting cisplatin, pemetrexed, and carboplatin, and bevacizumab with Pambro here in the US. 2 of these drugs are not even available in Cameroon if she wanted treatment in Cameroon. It's sad, but just the fact that she got surgery without a staging workup, it's not everybody who practices like that. But even if she needed chemotherapy, she's young. Would she have had it? How long would she survive back in her environment? So this is one of the cases I did talk about. The other case was also a 70-year-old female whom I was called for. She was a mother who had been having hematuria, but she lived in womb and could not really get enough of workup at the time. I think that was a problem. Her kids invited her to the US. We finally discovered she had 3 cancers. She had a bladder cancer, she had lung cancer with mets to the brain already, and she didn't know, and she had mild lymphoma. She passed away, and I did talk to the family. I was going to just talk about this case, showing you she lived for an additional 2 years, but these are all situations that if she was in Cameroon, she would have passed away, and it would have been typhoid, malaria in some places, just because of the way we're trained and the way we treat patients. This one is a scenario I've had more than 30 consults over. I'll tell you a good story, and the bad part of the bad story about it is that I've had multiple young girls consult me, or family members consult me. My younger sister just got diagnosed with breast cancer. What are we going to do? This case here was a Cameroonian immigrant in the US who is 25 years old, and she was regular breast exams, discovered a lump, and went in and was found to have stage 1 breast cancer. She was ER/PR positive, HER2 negative. She actually did get a lumpectomy, depending on how you want to call it, a partial mastectomy. I don't want to use semantics for people to quarrel over it. And she had an oncotype that was done, and it was quite low, so she did not need chemotherapy, so she got hormonal therapy. She's still on hormonal therapy. Why do I present this case? There have been multiple cases like this, which with the regional hospital in Bamenda, we have reinforced that everyone needs to get immunohistochemistry because it directs treatment. I did a series on breast cancer about 2 months ago, where I insisted on that. And the Cameroon Cancer Association also had a seminar almost a month after, and they reinforced that because we have been talking about it, and a lot of people drew it to their attention. Where every breast cancer patient needs immunohistochemistry, you cannot treat them without knowing that. That's the basics, that's the tenet, and it has been existing for 40 years. It's nothing new. There are newer things in breast cancer that we should be talking about, but not back to the basis. Meaning that all hospitals, actually, it's quite a pity that La Cantini cannot even do immunohistochemistry for that this is quite a big hospital. So it shows you where we put our finances. So these cases are meant for you to reflect and for us to reflect about what is happening. The next case here, which I present also, is a young guy who came, an elderly man, 73-year-old, and was found, actually moved to the US and was going back to Cameroon. And while he arrived Cameroon, he had generalized edema everywhere. The kids were worried. They sent him to Douala, l'Hôpital General. They did basic workup and his kidneys were failing. Since he had papers in the US, the kids brought him back to the US. He was found to have prostate cancer. He has had it all this while. His PSA was one of the highest I've ever seen. 4,000, that's 46,000. The kids call me. He's presently got nephrostomy tubes put in. His kidneys have improved. He was started on chemotherapy. He was started on Lupron shots. He was started on a drug called Nubeca. That's Dodoma. And he's pretty doing well. The question was, if he stayed in Cameroon, what would have happened? Are we going to be able to take care of this guy? Were we able? And all this while, what can we do in the system in order to improve this? This is another case I was consulted almost a month ago. This guy actually migrated to the US in order to come see how he can help his family. He's 63. He's been in Yaoundé for a long time, complaining of headaches for more than almost 4 years, on and off. And when he moved here, I advised that he goes to the hospital, though without papers, and complained of the visual problems. And they did a CT scan. They found a lesion. They did an MRI. He had glioblastoma multiformis. He's dying. He came here to work. So he finally got neurosurgery done. He's getting chemoradiation right now with temozolomide. And he has an Optune. Just because he has cancer, he's being covered. This is sad. This is something that would have been discovered many years ago if he had sick medical care. The question really will be the location of the tumor. How apt are we? This shows you how multidisciplinary cancer could be. And I think the last case here, without calling names, we're just going to present. This is the case I was talking about, a 24-year-old young lady who had hemoptysis recently and was found to have, they had a bronchoscopy actually done in Cameroon, and was found to have squamous cell cancer of the lung, which is intruding into the bronchus. She's stage 1 from imaging. The question really becomes, stage 2, sorry. The question becomes, do we have good cardiothoracic surgeons to take this out? This is going to be a discussion here. I really need to know from those who are here because she's in Cameroon right now and she needs help. If not, are we going to be able, with this 24-year-old, the only other chance for success in Cameroon, there are many things I could do in the US, was to do chemoradiation and get her, is she going to be able to afford it? And this really becomes where we need a cancer policy in place. These are not the most frequent cancers in Cameroon, but this was just a call for reflection about what I do have. For those who know me, that I'm an oncologist, and some of my colleagues who are back home, I've had pancreatic cancers, multiple of them, colleagues, parents, and brothers and sisters. I've had gastric cancers recently. I've had so many other cancers. I do tumor boards with the regional hospital, and they are amazing. I also participate in the tumor boards in La Cantini, which I'm not very pleased about. Now, when we talk about the rest of the presentation, I'll try to be as quick as possible, is when we talk about cancer care and why we need a strategy to help to treat cancer, is just because of things like this. Majority of cancer patients that are wealthy in Cameroon do seek care outside in India, and also do seek care in Europe and in the US. Those who cannot afford it never actually have a diagnosis, because you need good imaging, you need pathology. We don't have a habit of sending path for everything that we take out during surgery. Treatment becomes a big issue. We have few hospitals, which we're going to look at, who are able to take care of cancer patients, but we have been focused on training physicians without being focused on training the auxiliary staffs that are going to be able to give this chemotherapy. If you do have a good oncologist, without a good oncology nursing team, without a dosimetrist, without a good physicist, without a good radiation oncology team, you are not going to be able, or surgeons, you will not be able to actually help cancer patients that much. Lost wages is something that we will talk about. There is also other things that you see here that are pretty important. Now, when you look at the statistics, which is skewed, this statistic is not right because it's actually based on, you will realize certain things, the statistics for cancer, this is the most recent I could get from Cancer Today. And you realize that the most common cancers in Cameroon are the ones that you can see with your eyes. Actually, breast cancer can be seen. Cervical cancer, you examine the cervix, you're going to see the cancer there. Non-Hodgkin's lymphoma, you're going to see the mass growing, either Burkitt's or any of the other ones. So those ones, you can see them. Things like colon cancer, you need to actually do a colonoscopy. You need to do imaging. So the statistics for those cancers will be low in our setting because we don't have the habit of doing those tests and we are not able to do them widely. Breast cancer, you can see it. You can see for men, prostate cancer, you do a PSA, which is commonly done. And majority of the time, Kaposi sarcoma due to HIV and non-Hodgkin's lymphoma. So here is the statistics. You can actually look at what the global statistics looks like and compare that with Cameroon. Now, there are other cancers that I feel they are underdiagnosed back home because we don't have the capacity to actually screen for them and test for them. So you're going to underdiagnose them. A lot of them die from other things, but no one knows exactly what is happening. How many people, we have good urologists in Cameroon, but how many people do get cystoscopies when they have hematuria? Few of them. How many urologists are available to do that? And do we even know the prevalence of that? So here is actually showing you also the mortality of cancer in Cameroon. The data is, some of the data is out there, but Cameroon has very limited data. Most of this data is really based on simulations. And here you would see the case of Africa. Now compare Africa to Cameroon. You realize that the most common cancer in Africa is still going to be breast, prostate for men. Cervical cancer is super common. And that is why the initiative by Cameroon to be able to vaccinate young girls and boys against human papilloma virus is super important. And that's one of the ways we can actually eradicate cervical cancer in Cameroon. And in the rest, colon cancer follows in the rest of Africa. The more developed your country is, maybe given to because of nutrition and also techniques in diagnosing patients, the more you're able to actually diagnose colon cancer. Liver cancer is also prominent in Cameroon because of hepatitis B and C and alcohol. So that's one other thing. Now here you see some of the data. I'm going to leave that. Now, what makes cancer really difficult for us to fight and control it is really as a result of us getting to realize that cancer is not one disease. Cancer is multiple diseases, multiple of them. And it's one of those things that you need to understand it very well. There are multiple types of cancers. In Cameroon, we train oncologists right now, but we don't train hematologists, medical hematologists. So leukemias and lymphomas are going to be difficult cancers to manage. Even solid cancers in themselves and the principles behind managing them, it's something we need to reflect on how we're going to move forward. There are multiple types of cancers that we can talk about, which exist also in Cameroon. There are carcinomas, sarcomas, lymphomas, and leukemias. This is just a brief summary. Looking at the global burden of cancer, you realize that Africa is still not having the burden just because we lack diagnostic tools. We are having an epidemiological transition. We are living longer and we are seeing in our families that people are dying, but is this statistics capturing this very well? It becomes a call for a discussion really, and how Africans can come together and bridge the gap that is existing between the Western world and Africa when it comes to cancer, even availability of drugs. So in the world, the most common cancers, breast is the most common in Cameroon. Colorectal is actually the second most common. And then you have lung, cervical, stomach, and that's for women. And then men is lung and prostate, because you do have, the Western world has had smoking for a long time. Also in Cameroon, we have the firewood kitchen. We have all of that, which is equivalent to kind of smoking. That's why you find lung cancers may be more common in women than in men, because they are the ones who use firewood kitchen and they get soot into their lungs. This is cancer mortality for the world, which I'm not going to lay a lot of emphasis on when it comes to this. This is the most recent. So here is the data for Cameroon, which I would reiterate. If you want to fight cancer in Cameroon, what do you need to do? We are not yet apt in order to treat most cancers, but we can fight cancer. What can we do? Prevention is better than cure. We all know that. So if we are able to screen early breast cancer, I think all the regions, the Southwest region just got a mammogram, I think so, from the ministry. The Northwest did also. I don't know about the other regions. If we can screen for breast cancer and just adapt whatever guidelines we love to adapt, if we don't have ours. It could be the European guideline, the American Association of Oncology, it could be the task force, and screen women and diagnose them early. We will be able to prevent a lot of women from dying from breast cancer. Cervical cancer, we've been doing a good job. There have been some screenings, some pap smears being done in Cameroon, but we still have accessibility and acceptability to the papilloma virus vaccines is very low. Prostate cancer is a big elephant in the house because Blacks are more prone to getting prostate, not excluding Cameroonians, are more aggressive prostate cancer. Now, non-Hodgkin's lymphoma, that becomes a bit tricky. Kaposi, the prevalence is decreasing because Cameroon has done a great job with HIV. So here you can see, we've talked about this already. This is a very important map of showing you where cancer centers are located in Cameroon. And what is strange is that the prevalence of cancer is reflected on where these centers are located. Where there are no cancer centers, the prevalence of cancer reported is low. And the reason is because we are mostly using retrospective data. In the Northwest has the highest prevalence of cancer in Cameroon because we do have the Bingo Baptist Hospital. We do have the Bansor Baptist Hospital that are one of the best cancer treatment hospitals in Cameroon. From all anecdotal data, when you look at what they do, they follow the guidelines more than most of the big hospitals. And I've looked at what they do, even when they refer patients back to Yaoundé, the management is never as good as what they were doing. But they have their own flaws, which we can only reinforce and help them build their capacity. I think that's what we should be doing rather than criticizing. Baptist Hospital in Mutengene also does some cancer treatment. There are certain surgeries are done in multiple hospitals, like the regional hospital in Bamenda and other regional hospitals, and other intermediate hospitals in Cameroon. Now, we do have some other hospitals like the Mbopi Baptist Hospital in Littoral and also in the central region where we have L'Hôpital Central, L'Hôpital Général, and L'Hôpital Général Douala. The thing that bewilders me and makes me feel really sad about the situation in Cameroon is that you could have a cancer center like L'Hôpital Général where they see cancer patients, but the MRI department is not working. But the government goes and put an MRI in SIC, or what they call the new center. So it's like people don't reflect that you want to build a holistic cancer treatment center that has everything. If the L'Hôpital Général's MRI is not functioning, it needs to be fixed. If they have to have all the available resources to take care of cancer patients if we want to make them a reference. Even when we send personnel, those are things we have to think about. The Douala General Hospital is much more equipped and always better managed. Now, I would go over to just talk about screening guidelines. Here is just data globally, which I'll not lay emphasis. Cameroon has no policy when it comes to screening for breast cancer. And we need a national policy. These are things that we can do in order for us to reduce mortality. So we need to put in a national policy. This was gotten from WHO website. as of 2022-23, there was no policy. So what we need to do is say that we're going to screen breast cancer for every woman. Let's take the age 40, we can take 45, we can take 50, depending on what guidelines you're using, and screen every year or every 2 years. These are the different things you can do, which we can discuss when we're going to talk about discussion. For colon cancer also in Cameroon, there is no screening guidelines, there's no policy in place. So these are all things that we need to do. Prevention is always better than cure in order to get a policy in place that we can screen. We do know that also Blacks are more prone to having colon cancer in the Western world. Even among Africans that have immigrated here, a lot of people die without even knowing that they had colon cancer. So here is for Cameroon. When I was looking at WHO website and also investigating, there is no national guidelines, but there are people who do screen. So here you can see these are some of the things you can do in screening. Cervical cancer, same thing. There is evidence that is available here. Gynecologists are doing a great job in Cameroon trying to screen, but we need to have guidelines in place and policies. Who needs screening? Who needs a vaccine? The vaccine part is taken care of, but the acceptability and accessibility of the vaccine is a problem. So we need education in that aspect. Now, risk factors for cancer that we need to talk about. This was something we never really, in order to bridge the gap, we need to be able to fight new cancers and get ourselves active. Here, there is one thing we cannot avoid. They are modifiable risk factors and they are non-modifiable risk factors. For non-modifiable risk factor, your age. Africa is an aging population. We're getting older. We are living past all the infectious diseases that used to kill us as kids. Malaria has a vaccine, which I think we'll talk about that in the next 2 weeks in the town hall. We are getting to live longer. The older you become, the more prone you are to cancer. So there is no risk factor to getting cancer as much as old age. No matter the cancer, breast cancer, colon cancer, no matter whatever cancer you look at, you would see there. These are modifiable factors that we are not, I think all of you here do know the factors that do cause cancers. We do have smokers in Cameroon, but we are not one of the big smoking nations in the world. So that makes it a bit very important for us because smoking alone is responsible. Smoking alone is responsible for more than 18 cancers that you can think about alone. Human papillomavirus is responsible for about 5. There is cervical, penile cancer, anal cancer, head and neck cancer that people don't talk about. These are all things that are related to sexual promiscuity and also the number of sexual partners. So here are the things that you can do. I think you all know this, but these are things that we can advocate for. For breast cancer, there are several risk factors, which we have spoken about in the town hall multiple times. And this is just to show you that there are other factors that we could talk about, such as genetics. How prevalent is the BRCA gene in a Black person? We do know that Black men are more prone to having prostate cancer and more aggressive prostate cancer. And I'm getting to see more BRCA too. And also that's even one of the reasons why we have a lot of Africans, because we have not tested, who also do have the BRCA2 gene and they never knew about it. Cervical cancer is the second most common cancer in women in Cameroon. First most frequent gynecological cancer, we do know that. And right now, we have, this is the burden in the world. The rest of the world is getting out of cervical cancer. We are still in it. We know the pap smear has existed for years. And we do have modified testing that has existed. Just by doing vaccination, the US has trended down. You can see this. And as I told you, New Zealand has practically eliminated it. Most women who have cervical cancer in New Zealand are women who are migrants from India and other countries coming into work. So this is one cancer that we have been able to eliminate. Why can't we do it in Africa? Why can't we do it in Cameroon? And I think I saw the delegate of the Southwest here in the call, and they're doing a great job trying to educate people to take the vaccine because Cameroon does have it. Now we need education. We need to bridge the gap. There's the Gardasil 9, which is available. And it actually does not only reduce cervical cancer, it reduces penile cancer, men who have squamous cell cancer of the penis, anal cancer, it reduces head and neck cancers. So these are all things that we need to be able to educate our population and tell them these things are done everywhere. It's not only in Cameroon. Here is just a landmark of what is done in cervical cancer, which I'm going to pass. Now, there's also hereditary factors, which I will not lay a lot of emphasis on because we don't test a lot of people back home. So here are several genes. I had a Cameroonian who called me once. She had breast cancer, but she also had Lynch syndrome when she was tested in the US. Most of those in Cameroon will say, oh, this doesn't exist. I've had multiple Cameroonians who have been BRCA1 and 2 positive. I've had an APC gene from Cameroonians also. And the last one I had, which was shocking, was von Hippel-Lindau syndrome, which she also had breast cancer, but was found to have von Hippel-Lindau because her dad had kidney cancer, and they got to test her genetically, it came back positive. So these are the cancers that I would advocate for us to screen in Cameroon. If we're starting a policy, we want to propose a policy for the government, we need to have in place colonoscopies in all 10 regions, mammograms in all 10 regions, pap smear and P and HPV testing in all the regions and sub-regions. PSA screening should be done, though we are going in the US, we no longer do it as screening, but we're going to go back to it in the next few years because of some controversies. So here are some screenings and the timeline where these screenings need to be done, what age you need to do them. This is just a little guide which I can share with the rest of you if you want to make guidelines for the country. These are things we're going to propose so that our government, treating cancer is going to be very difficult, but preventing cancer is something we can do easily. And these are all things that we do have good advocates for gastroenterologists who are Cameroonians, both in Cameroon and in the diaspora. They're doing a good job in multiple countries, like Dr. Akwe, I know Dr. J. Bazil, those are all, and I know people back home like Zume Maxel. There are all a lot of Cameroonians who can get to advocate for colonoscopy, do proper colonoscopy, and not forgetting my big brother, Dr. Ivor Dieter. They can help us get to screen Cameroonians, and finally, we know why people are dying. And also help the Department of Gastroenterology in proper training. So breast cancer screening is something we've talked about in the town hall multiple times. I'm not going to lay emphasis on that and how to get specimen. And also, I would never stop not talking about how you do staging. Never treat any cancer. I'm saying this to all those who are family doctors and primary care doctors here without staging these patients. There is the European guidelines, the ESMO guidelines, which is available in Cameroon. Just Google it, please, guys. It changes every time. There is also the ASCO guidelines. Google it, stage your patients properly. There is this old addict, which the surgical pride in medicine has dropped because it's not every time you do surgery that you're going to help a patient. And most of the time, patients think you're helping them. I've had multiple patients who have had mastectomies who never needed it. 2 weeks after, they were complaining of bone pains, and we realized, I said, go scan them. They had bone mets everywhere. The mastectomy just was useless. They spent money, you got money, but you may have been ignorant what you were doing, but you did harm to the patient. You didn't do any justice to this patient in either survival or anything. So we need to get back. As a good surgeon, you need to reevaluate those who really need surgery. So bridging the gap is understanding who needs what kind of care. Here is just how lung cancer is staged. I'm going to go through this quickly. And I would end up with the last 5 minutes just talking about how we treat cancers overall and where the gap is. You do see it's a multidisciplinary team where you need the surgeons, you need the medical oncologists to be able to give chemotherapy, hormonal therapy, targeted therapy. At times you need bone protection. At times you're going to need radiation department, which is one of the most expensive to have. In cancers, we want to figure out if this patient has localized disease so we can use localized treatment, or systemic disease where localized treatment is useless. There are some terms when we talk about adjuvant and neoadjuvant. Those are all things I can talk about later on. I'm not going to lay emphasis on this. But the type of cancer treatments are summarized as getting patients to have surgery when it's needed, radiation therapy when it's needed and appropriate, chemotherapy when it's needed, and for patients who may not need chemotherapy, don't give it to them. I've had multiple patients with metastatic disease with no visceral crisis, especially with breast, getting chemotherapy and dying. There was this young girl's case I had 3 years ago. She got chemotherapy in Douala so long, but when I got to do her immunohistochemistry, she was ER/PR positive, 100%, and never ever had any form of hormonal treatment, which may have stabilized her cancer for more than 5 to 10 years. We do lack palliative care departments. So those are things we should train palliative care nurses. We should train the other supportive staff in Cameroon. I think that's where we should stop opening and valorizing medical schools and start training the other people who are going to work with these doctors you're trying to train. We have reached a point where it's a breaking point in Cameroon, where we keep proliferating one thing that we know without even thinking about how the medical field works and the other people who have to work with the others that you're training. So these are different discussions that we have had in the town hall before, but this is something I always emphasize on. 80% of breast cancer is estrogen and progesterone positive. They may not need chemotherapy. You need to test them. Without testing them, oncologists are going to be doing harm to patients. Do not harm patients. There are 5 basic ethical principles I always talk about, but the 2 ones is beneficence is to do good. Maleficence is to do no harm. And at times the patient doesn't even know the difference when you're harming them. So a lot of times we harm patients and they don't know it, and they feel and they thank us for harming them. And that's the sad part about life. And we are getting to the point where we're going to start getting sued in Cameroon because people are getting knowledgeable. So this is an important slide. I'm not going to lay emphasis on it. It's just how breast cancer is treated. Radiation therapy is important. I'm not a specialist there. I don't know if Sydney is around and others. And there are other radiation doctors in Cameroon, but the problem is the auxiliary staff, maintenance of equipment, training dosimetries, and all of that becomes a big problem. And even giving adequate radiation. So other treatments are things that our pathology departments do not do. Cancer has moved away, and cancer has become precision medicine. So these are things, targeted therapies are not available, but right now that's where we are. It's going to take us another 20 years, or we need to do things rapidly in order to get to this phase. When I have a patient with lung cancer now who is metastatic, I do an NGS. The next generation sequencing, majority of them will be EGFR positive. I will start them on a pill. The pill may even have less side effects than your diabetic pills. And they may live as long as you can imagine without even getting chemotherapy. That's where we are. So I'm not going to lay emphasis on this. This is going to be a discussion for another day. And this is just the guidelines of how we treat patients and what we do. There are different other types of treatments that we could talk about, which are very important in Cameroon. Access and availability of treatment, which I would say the Clinton Foundation and the Health Initiative has been trying to get Cameroon to get access to multiple chemotherapy drugs, hormonal drugs, and I'm going to call on Dr. Yauber to continue this effort while working with the government. Here are some magical pills that we use. This is one cancer that I'm going to do a training on. Why? Because it's an easy cancer to manage, and I realized that many people in Cameroon get prostatectomy when they don't need it. Why do they not need it? They don't need it because majority of them have metastatic disease, and doing a prostatectomy is not necessary. So prostate cancer, how to treat it, and education around this. Most of the urologists here do know, but we have few urologists, so we need to train our general practitioners in order to identify and refer patients. We do have side effects of these drugs. We're going into the era of precision medicine. We are not yet there, but the goal is going to be to try to prevent cancer in the first place before getting into treating cancer with precision medicine. I will be a big advocate on training back home in order to reinforce our pathology department, see how they can get to this point. I can do a whole lecture on this for days upon days on how we are treating different cancers right now. But I think we need to go back to our basics, reinforce our pathology department so that they're going to be able to give us the right diagnosis, reinforce our radiology department so that they will be able to do biopsies for us. Interventional radiology is a field that is lacking back home. They are taking over most biopsies and surgical techniques, but IR in Cameroon is very rudimentary. And we need to work on improving that. I think there were some interventional radiologists that came to l'Hôpital Général in Yaoundé some few months ago, and they were helping in training of different techniques, but what can they do in a few days? So we need to really train our residents and actually improve them. This is a patient who had melanoma, one of my patients. I did take his permission. Before he got targeted treatment after melanoma, he just got a pill. And after getting the pill, this is how he responded. It's vemurafenib. So we are in the place where we should be able to use targeted treatment in Cameroon, but we're still far away. Why? Because we need to develop other departments. Here is just hormonal, and there is immunotherapy. I was very saddened because every cancer in Cameroon, actually, right now, almost every cancer, the protocol is to add immunotherapy, but we don't even have availability. The last time I checked, most Cameroonians go to India and they go to other places to get immunotherapy. Even if you want to import it, it's about millions for single treatment. So we really need a government policy like how HIV was done in the early 2000s, and Africa actually had to hold the rest of the world responsible and accountable for us to get this treatment available. There are things that we do right now. We're doing genetic treatments. We're doing CAR T cells. Those are all miracle treatments that availability in Africa is going to take time. But how are we going to bridge the gap is education. We need to educate our oncologists about what is available, what can be done, what is in the horizon. This is a paper which was my last few minutes is just to reflect on this. This paper, Cameroon writes beautiful papers. We have a national strategic plan for prevention and management of cancer. We did this, I think, with child, and we had multiple resolutions that we're going to do. The problem is how many of these things have we achieved? We're already in 2024. This was the plan. At the time, we did a census to figure out the number of specialists that we have. Palliative care nurses, we said 50. I am not even sure of that data of 50. Those who were claiming to be palliative care nurses, if they were really trained as palliative care nurses. Anatomo, cytopathologists, there are many in Cameroon. That number could be true. Radiologists were many, now there are more. Most of them are trained and they moved to France and they moved to the US, like myself, which is crazy. And we need to fix that problem too. Gynes and experts in oncology, they said 10. But I don't think there was any gyne oncologist few gyne oncologists that went to residency and fellowship training in gyne oncology. It's a very important specialty that people need to, apart from Professor Doe, I don't know how many, those I know about, but maybe the others will correct me. Biologists, there are many in Cameroon. The number 10 is low. I did train as a biologist, as a clinical pathologist in Cameroon. But when it comes to important specialties that I don't see here, and even those that I see, oncology nurses, you need ENT doctors, you need pediatric oncologists with just 3. And I think those are spectacularly well-trained doctors. I may be biased, but I'm against the way we do train internists in Cameroon. I prefer the aspect of general internal medicine and subspecialties. And that's what pediatry does, and they are super good doctors who are, no matter the numbers that are available, they are super good. Hemato-oncologists, Cameroon doesn't train them, but we do train medical oncologists, but in the US, it's a combined specialty. So these are all things we should look about, human resource. But are we training the auxiliary staff? Do we even list them? Do we need physicists? Do we need dosimetrists? Do we need oncology nurses? Do we need spatial radiology technicians that are going to help us to be able to run some of these spatial tests? Are we even training them? Now, these were scans and MRIs that were functional. I think this has changed, especially after the African Nation Cup. A lot of these centers did have scans, but what was very interesting, I was looking for that document to put here, is that in Cameroon, you have a functional MRI in Bafoussam, in the new hospitals that were created, but that is not even a cancer center. But you don't have a functional MRI in l'Hôpital Général Yaoundé. Maybe it's now functional. You have a functional MRI in Garoua, in the new hospitals that were created. I always forget how they are called. But you don't have a functional MRI in l'Hôpital Général in Garoua. I do not understand policy. I know we do talk to ministries, and these are all things that we have to talk about and get to. If you want to make a good treatment center, you need to have holistic treatment and diagnostic machines in those places. These are areas where we have cancer centers, so-called cancer centers. L'Hôpital Général Yaoundé is a handicap cancer center that needs a lot of input for those who have worked into cancer center to make it holistic. L'Hôpital Général Douala is a good cancer center that may just need, I think they have always been a good hospital, well managed. L'Hôpital Central Yaoundé, no, they don't even have an MRI. They are not even capable of doing radiotherapy, so it's not a cancer center. La Cantini, it's a pity because the pathology department and even for all the others are unable to do immunohistochemistry. How do you even diagnose patients in the first place? Bingo is doing a good job. They're building a radiation oncology unit. We're looking forward to that. Bona Samar is just a district hospital. So these are other things that we can talk about. Here are the location of some of those centers from what I found out. The goal is, what do we do getting forward? How do we in the diaspora help these different areas and improve them? This is an example of a good job. I have no stakes in this company, the Cameroon Oncology Center. I have no stakes in them. I think we've invited them in the town hall and they have promised to come in several times, but we're still waiting on them. They are doing kind of a good job. I've had some patients there and they will tell us what they're doing. So my last slide is really to go back to where can we bridge the gap better in Cameroon? I still think prevention is the mother of all policies, though as a clinician, we get humbled by public health specialists because if you take for the past, I think I always quote this, the past 120 years since the 19th century, after WHO did its analysis in 2000 to figure out things that have improved healthcare, as physicians, we did no value really. So what has improved healthcare in the past 120 years has been, number one, hygiene and sanitation. Number two, preventive medicine. What is preventive medicine overall? Screenings, vaccinations, making sure that we screen patients, we prevent things from happening rather than try to treat things. The next thing is the discovery of the antibiotics. So I put the infectious disease doctors high up there. And the last thing is smoking cessation. And finally, all of the rest of things we do in medicine have had little or no impact. 2020 was the first time in lung cancer that we could see that our treatments actually improves lives and people survived based on that using data from statistics. So I'll end here, Elvis and Kate and Brian, by saying prevention is better than cure. And I think the way forward, as I said, is for us to work with the Cameroonian government, work with the private sector, try to put in place prevention from those in the diaspora, try to reinforce knowledge, those who are back home, go back to our medical schools, encourage the training of other auxiliary staffs, and stop proliferation of medical schools and think that's going to be the solution to our healthcare problems. So I think we can have I'm done now, and over to you guys. Let me stop sharing.
Yeah, thank you so much, Munoh, for that presentation. I think I think there's someone talking. Okay, fine. So what else can we say? I think you've done a ground round for cancers generally today, and with a lot of information, but also with a lot of passion. We can see that passion whenever you talk about cancers, and for generally most of your presentations. And so before we move into Q&A, which Brian will be handling, I think there are some key issues that you raised, and I can say with all the information that you've given us tonight, I think you mainly focused on prevention being the key, and also on education, which are really very, in the scale of things, really cheap public health measures that we can apply rather than to wait to clinically provide care for people who develop cancers. And so prevention, prevention, prevention. And the skill or the art or the science of prevention, it's something different. I'm also very happy you talked about the National Cancer Policy, which was written some few years back. Unfortunately, or fortunately, it was written, that's good, 2020 to 2024. We are already in 2024. What has been implemented? I mean, if we go back to do an evaluation as maybe public health specialists or other individuals, we probably will be shocked to see the level of implementation. But however, it's a good thing that we have that document, and we have to look forward now. So I would rapidly slide over to Brian, who is going to handle the next stage of our discussion. And obviously, we hope to have a very interactive session tonight. So over to you, Brian.
Yeah, thanks a lot, Kate, and thank you, Dr. Munoh, for your presentation. I took a lot of notes. I think your passion for closing the cancer gap in Cameroon was very, very clear, and this was a very deep and deeply insightful presentation. I think you provided us with some really important context to the current landscape of the problem in Cameroon. I think you highlighted some critical deficits that I think we have to work on. You talked about pathology services and the need for specialized services and all that, and the need for training, education, and several of these. I think it was very clear through your presentation that we have a long way to go, and there's a lot that we can do to close this gap. And I'm really hoping that the Q&A we're going to have today would not only really want to provide an opportunity for people to ask questions, but we really want to brainstorm on ideas, on practical things that we can do that can serve as a building block to all the things that we can do. I did share a document that Dr. Munoh shared, the National Strategic Plan for Cancer in Cameroon. So I really invite you all to have a chance to glance through that document and see what was implemented, where we are from when it was written several years ago and where we are today, which Dr. Munoh nicely summarized today. So thank you very much. So if you have any questions, any contributions you would like to make, I would like to invite you to simply just raise your hand. I will also try to glance through the chat, and if there are questions there as well, I would try to pinpoint them as well. So I will start the first question. I see Dr. Ferdinand Mukumbang is here. Prof, it's really good to see you, and thanks a lot for joining. It's really a great honor to see you. Over to you with the first question.
Thank you very much for having me, and thank you, Dr. Munoh, for such a brilliant presentation. And of course, your passion for cancer really speaks through your presentation. Of course, it's your specialty. So I really was happy to see the fire in you to that regard. Moving on to my own specialty, implementation sciences, and in relation to cancer, in South Africa, they are a little bit big on preventing cancer. Cervical cancer in particular, which you mentioned that a lot of countries are trying to eradicate from their population. And so the HPV vaccination is a program that has really been adopted widely. And what they've done is that they've gone even right down to primary schools, and they are vaccinating all the female children in primary schools in South Africa. This is a very, I wouldn't say simple, but a very practical way of doing prevention, like you mentioned. Is there a consideration for such a thing in Cameroon, and is it being implemented?
Okay, thank you very much, Prof. Mukumban, for that brilliant question. If those who don't know, this is one of those who actually motivated me to go to medical school. It's my big brother. So it's important that we know that Cameroon has a policy actually for vaccination. And I think if the delegate was here, he would have actually tell us. Cameroon has a policy in place. The Gardasil 9 is being given in Cameroon. The problem has been that vaccine has been staged with a lot of fertility issues, meaning there has been a lot of propaganda against that vaccine in Cameroon. So the government actually provides it free of charge. And I think Cameroon is going to make, I don't always want to be negative. Cameroon is going to make a big stride in cervical cancer. It's one of the cancers that since 2000, when I got into medical school in 2001, Cameroon we had been doing pap smears even when we were medical students, trying to screen. And I've always known Cameroon had a wonderful gynecological service in place, which was pioneered by the late Professor Leke and NASA and so many others who were really visionary physicians who looked at gynae cancers and actually forced the government to incorporate it into most of its policies. So Cameroon is actually one of those countries in Africa where the HPV vaccine is available. But the question is, how accessible is it? How much do the people even want it? What are the strategies are we using to promote it? Because cervical cancer is the biggest cancer prevention problem in Africa that we can eliminate. Multiple countries have shown us that they can do it. The US is not even a good example, but the numbers have fallen so drastically that each time I see, it's sad for me because each time I see a cervical cancer patient here in the US, it's either a Black person or a Latina. And it's sad because it shows socio-economical issues. It actually shows how much the determinants of health affect health itself. So Cameroon is doing a good job. I would want to hear if the delegate is here to talk about what strategies they are using, but I know it's available. Last 2 years, there was a big promotion where women were advertised. All the popular women came up. There were banners that were made in Cameroon. In Cameroon, I think it's from the age of 9, boys and girls now can get it. Human papilloma, the strand 16, 18, 32, 34, those strands, we're doing Gardiner 9, which has other strands, are available to prevent multiple cancers. We're talking about cervical. We're not talking about penile cancer, anal cancer. We're not talking about majority of head and neck cancer that is HPV related. Those are all HPV related cancers. And those cancers, once you vaccinate people, if you know about this American actor that was, I think it's Michael Douglas or which of them, who acted in Basic Instinct, he had head and neck cancer that was HPV related. So those who do oral sex, those are things we don't want to talk about, but that is it. So these vaccines are super important. And I think the government in Cameroon is doing something about that aspect of it. That's one aspect I want to applaud them. But where they are lacking is screening. There is no national policy for screening women, which other countries have. There is not a national policy. There are single individual policies, but we need a national policy where we put in place. Okay, thank you. If anyone wants to add to Ferdinand's question, you can just chime in.
Yeah, I just want, yeah, definitely love to hear additional feedback on this, and I also want to really acknowledge Dr. Ferdinand's point. Dr. Ferdinand, for those of you who may not know, he gave a presentation here on the importance of implementation science last year, and implementation science is so important because it's what really bridges evidence-based interventions and practical real-world applications. So kind of bridging that gap between what is sustainable and culturally appropriate for the population. So I think that's a very important aspect of science. As we build interventions, we want to be able to transition those interventions to the populations that need it the most. But Dr. Munoh, one of the things that Dr. Ferdinand talked about was about this screening thing. But I was wondering, what would you characterize as top priorities for Cameroon, given the limited resources you have? If you had like top 5, 10 priorities for improving cancer screening in Cameroon for the next 5 to 10 years, what would be your top 5 priorities?
Oh, thank you for that wonderful question, Brian. So what are the most prevalent cancers in Cameroon? That's the question we'll ask ourselves first. The most prevalent cancer in Cameroon in both sexes is breast cancer. So my top priority is going to come in with breast. How do we prevent breast cancer? All 10 regions and sub-regions need to have a mammogram and a breast ultrasound, and we need to train radiologists and radiology technicians on how to screen and properly do it. Mammograms are one of the most difficult exams to interpret. Dr. Tambe, if he was here, is going to tell you, if you're not properly trained, you can proliferate mammograms the way you like. If you don't have good technicians and good radiologists who can read it, then that's going to be a problem. So we need to go back to our training in our medical schools, train the radiologists to read mammograms properly, and train them to do stereotactic biopsies when they have suspicious lesions. That would be my number one, and make it available everywhere and make a national policy for breast cancer in Cameroon. Number two, what's the second most common cancer in Cameroon? In both populations is cervical cancer. You will not believe it. So what do you need to do for cervical cancer? We need to revisit the vaccine, be able to understand why people are not accepting vaccination, bridge the gap, vaccinate our kids against human papilloma virus. Is going to reduce anal cancer, penile cancer, head and neck cancer, and some other cancers. If we do that, and we should have a national policy, which is easy, to start screening girls from the age of 20 up to the age of 65, and have that inscribed in the national policy, and train our pathologists to be able to diagnose and make pathology available. Those are schools, those are things that we should train people and technicians in order to be able to diagnose this patient. What's the third most common cancer in Cameroon? Prostate. What should we do? We should go back, be able to use the PSA, which is controversial, but the controversy is going to be analyzed and dropped soon. PSA is still important. Screen patients, get urologists. There are a lot of urologists that are trained. They are limited. Some of them may be on this call. They are well-trained, but they don't get to see some of these patients. Screen patients, get them biopsy these lesions, learn how to stage them properly, especially those who come in with bone pains. I've seen multiple men coming with bone pains and no one does a scan, and they get prostatectomies and all of that. And also make medications available to treat these patients. Now, other policies that can be added into my policy of screening is just, I think colon cancers are underdiagnosed in Cameroon, so we need training in that aspect. That's the additional one. Then we need to reinforce our pathology departments, reinforce our auxiliary staffs, get more schools for nurse oncologists and subspecialties, palliative care nurses, train people how to manage pain. Then we come back to oncology itself. Once we have done all those things, oncology is going to fit in, because we'll create a good environment for oncology to fit in. It's not by buying $1 million machines that are going to get bad in l'Hôpital General in 2 months that you're going to improve oncology care, that you'll see a difference. public health has proven to us the public health aspects, as I just emphasized, is what is going to make a difference in Cameroon.
Yeah, thank you, Munoh, and thanks a lot for sharing that. I think that's kind of important. In one of your slides, you did mention about the, I think you mentioned about mammography for breast cancer, mammography, the importance of increasing those capabilities. Talked about cervical cancer, prostate cancer, medication, therapeutics in general, colon cancer, and you emphasize the importance of palliative care. So I think I've taken a note of those elements. So thanks a lot for sharing that. I would transition.
Please, can I step in with respect to the diagnostics? Dr. Munoh, you mentioned about some important genes which could act as essential markers for the detection of cancer, like BRCA1, BRCA2, and we also know about some proto-oncogenes, which we know that once there's mutation, they could be linked to cancer. Why not try to look into ways that they can make rapid diagnostic tests using these essential cancer markers, which could be easily used as point of care diagnostics, and this could go a long way to really help in early diagnosis and maybe furthermore detection and treatment of these cancers. What has been done in that direction? Thank you.
Thanks a lot, Maloba. I think it's important. But before we get into the nitty-gritty of genomics and how we can use transcriptional medicine to diagnose things, I wanted, because we are not there yet in terms of diagnostic capabilities and next generation sequencing. So I think that's something I'll definitely like to pick Dr. Munoh's brain on that, on how we can address that. But the things that are within our reach, like screening and things like that, something that I felt that we should prioritize. But I'll get back to that point, which I think is very important, and how we can address that. Let's transition to Dr. Samuel Ginika, and then I'll come back to that.
Thank you, Brian. Thank you, Munoh. I mean, this is, as usual, always an excellent presentation. And, you know, you and I, we've talked more about this, and I want again to appreciate you. You have had the opportunity to talk to our women down in Dub. And this is more of additional information. I shared a simple guidelines that we have been working on. I think it was on the chat there, by Spider Network. They are based in Sweden. They are working with most of the countries in East Africa. And the goal, it is called Digital African Network for Cervical Cancer Elimination. And of course, my focus will be on the first 2 points. You have the awareness. In that program, they have awareness, they have prevention, they have after prevention screening before you get to diagnosis, treatment, and of course, as Munoh, we heard from the presentation, talking about palliative care. I want to give our experience on the ground. Awareness is a huge problem. We've heard Dr. Munoh talk about the HPV vaccine in DUP. For example, I think during my presentation, when I came to the town hall, we talked about that vaccine is at DUP District Hospital. But during our mission trip, we found out that it is there, but they're not using it. And during our education, the women they have accepted. We have more than 300 women that come through our center every month. They have started giving this vaccine. So this awareness, this is where we can come in, those of us in diaspora, those of us who are here on the town hall. I think Munoh and I, we've been talking about some activities that we can do in that area. So the awareness program is huge. Before you even get, without the awareness, you talk about just a stigma about vaccine. Many of the women in DUP, when we started asking them, their concern was that they are going to make their children, especially the female, infertile. They don't believe that it is truly a vaccine that will prevent them. And during that trip, we went to FECOM. Many of you will know FECOM. They work for the city council in Yaoundé, and with gynecologists from Cameroon. They use the the method from the World Health Organization, that visual inspection with acetic acid. And this, they were screening women. These are professional women. During that trip, 37 women were screened, and they found 10 out of these women with some kind of lesions of uncertainty, and even neoplasia 1. So if we could just find a way to talk more about awareness, I mean, like I'm saying, prevention, which is the vaccine, before you even get to the diagnosis, how can we get that done? For example, right now, Rwanda, Kenya, South Africa, I'm part of that program. And it is something that if we're looking for a program to sponsor, I would say the first one would be awareness. How can we organize awareness on the ground? I think Professor Ferdinand talked about South Africa. You hear about even going down to schools. Education will be very, very crucial. And without that education, the vaccine, like I am saying, maybe we have some other doctors from the Northwest or the Ndop area or other areas that they can share that they don't even know that that vaccine is available in their district. It's already there. Not to even talk of reaching out to the people who are in need. So that was what I have. And to say that there are many of us here, we are working on the Biden administration is working on the cancer moonshot, and the goal is to eradicate cancer. And I think East Africa, there is just about 2 who are represented from the Cameroon side, and I'm aware of that. And those are the things that we can try to get involved to see how we can actually help setting up activities for awareness, prevention, before you even get to the diagnosis. And that will actually be huge. Thank you very much.
Yeah, thank you, Dr. Samuel. And I think yours was not a question, but more of a reaction and the way forward. And this can be part of the Give Back project. I've always said in the Diaspora Give Back project, which Elvis and Brian launched, is a wonderful thing that we can do always. Try to see how we can go and make changes back home. And you know, we have had this conversation for years, both of us. We've had presentations that I've given to mothers in Dub, in Yaoundé, and I was very excited to give them. Going back to Balobar's question, which I'll just address in a few minutes, Brian, maybe there are further questions that would come, is for years, there is research going on using cancer markers to identify cancer. Majority of them have not been very specific. Something like the PSA is a very important tool, but you need to know how to use it. That's why it became controversial in the first place, and we use them. You need to know how to use the CEA for colon cancer, and it needs a lot of training. You need to know how to use the CA99 for pancreatic cancer. You need to know how to use the CA125 also. So these are all markers. We have multiple markers, but a marker alone does not give you the diagnosis of a cancer. It could help you in a resource-poor country. These are all things that we could draw guidelines and try to educate people on how to use it. Now, going to NGS and genetic testing. As Brian said, we are still dealing with rudimentary problems. And as I said also, the driver of cancer, genetics is part of it, but genetics is not a main player. Age is a bigger player than our genes. There is the aspect of genetics, but even in breast cancer that we have studied here for long in the US, I'll tell all my patients who come to me, oh, I have a breast cancer, 40 years, but we do screen genetic for everyone, but few people are positive. Majority of them is just because they are women. They have been exposed to estrogen and progesterone, and they are getting old. So using genetic aspects in the Western world, we are doing that because we have a lot of finance. We were going to do it in Africa too. Running NGS, next generation sequencing, it's a complex talk. I think Brian knows I can give a talk on this for lectures upon lectures in the right environment. I love genetics. I love NGS discussion, but this is not really the right forum because we are not yet there. I treat cancers now. So there is this whole paper that came out that we have been discussing in oncology, we would stop, in the next 10 years, we'll stop classifying cancers as lung cancer, breast cancer, pancreatic cancer. We'll classify them as EGFR positive cancers, ROS1 positive cancers, KRAS positive cancers, BRAF positive cancers, NRAS positive cancers, NTRK cancers. Why? Because that's how we're going to drive treatment. And that is what is driving the cancer to grow. But skipping the basic steps, I believe so much, because maybe I'm a public health specialist, in things that have been proven to work with limited amount of money put in. What has worked with limited amount of money is understanding our basis that we don't have yet, going back to understanding the determinants of health and tackling those determinants of health, then we move forward. So I would stop there so that I know there are many hands up so we can discuss other things.
Yeah, I see that Maloba Johan is still up. You wanted to expand?
Yes. Yeah, thank you very much, Dr. Munoh. I think this is a very pertinent topic, which is very touching in Cameroon. And as we all know, the etiology of cancer is very diverse. And as you mentioned, like the mother cooking in the firewood, there's no way she can stay without cooking on firewood, which means she will still be exposed to that smoke. Yeah, I always want to go back to the question Cameroonians are always asking, and that we, the lay people, we always ask. And we are living in a country where many people could not make up to $1 a day, and cancer diagnosis and treatment is very expensive. So in this light, what can be done? What can this poor mommy in the village, who is cooking with smoke every day, do to prevent not having lung cancer or breast cancer? Secondly, there is a lot of saying, like in the case of prostate cancer, that maybe men are having it because they are not sexually active, that they have more sex, they can reduce prostate cancer. Is this true? Thirdly, there is a conception that in Cameroon, once you start chemotherapy, you are bound to die. That's what is there. That's what the people think. How I think Dr. Samuel mentioned something very important: awareness and education. We usually have the local radio station that usually speak in our vernacular that could pass a lot of messages, but those things are no more existing. Maybe with people like you, Dr. Brian, Dr. Darcy Evans, is something to help the ministry to start to look how they could promote some of these little radio stations where they can give little good health talk that can help this population. So how can we help this minimum like in special nutrition? Some people say when you consume antioxidants, maybe you pour warm your water, you put lemon, that it can reduce cancer cells. Are these things true? What are those food that these people can take? What are the practices that these lay people who don't have money can do to prevent cancer? Thank you.
Yeah, so you have a lot of questions embedded in that, but I'm going to summarize it. And this goes back to education and prevention. A lot of things you have said goes back to education, the nutrition aspect, the firewood kitchen, the aspects of understanding that sexuality and multiple sex partners could reduce your risk of one thing and increase your risk of the other. These are all things that are important for us to go back to our basis. And I don't want to always misrepresent what Cameroon is doing. Cameroon is doing a great job when it comes to certain things, but we need to do a better job. We have cancer experts in Cameroon. The question is, I think in this situation, we need to go back and make cancer a priority, get back, analyze the different risk factors for different cancers and be able to educate people. We need to educate our mothers about the risk of firewood kitchen and actually get scientists and researchers, which is happening in Cameroon, to get firewood kitchen where the smoke is tailored out of the kitchen into the outside, and other means of cooking without necessarily depriving them from cooking, but just creating better funnels for them to not be able to inhale soot. These are all things that we need to think about and work in our context in order to help prevent cancer. I am a believer of early prevention, which in cancer is multifaceted. depending on what cancer. Cancer is not a specific disease. Cancer is made up of 200 different cancers. And also early detection and the cure. What can we do to detect it early? Let's take, for example, I was discussing with Sydney the other day. If we start screening for lung cancer, like the little girl we have, and we discover that she has early stage lung cancer, do we have cardiothoracic surgeons that can take it out? Do we? Do we have them that can dare to do a cardiothoracic surgery on this girl? If the answer is no, then we need to go back to the drawing board and see what we can do to train these surgeons and train the anesthesiologists and train the anesthetic nurses who would be able to form a team where if we're diagnosing these cancers early, we'll be able to help. So in terms of the firewood kitchen, we need technology to improve cooking. We need to create kitchens that are actually meant, not preventing these women, but where they have furnaces that can direct the soot out. In terms of prevention, to me, prevention is always better than cure. When it comes to chemotherapy and death, some of them are right. And I'll tell you that my aunt, before she died, told me if I go to L'Hôpital General Yaoundé, I'm going to die from the chemotherapy. Is it true or not? It becomes very skeptical. Someone needs to do a research on it. If you're giving chemotherapy to patients where you are not able to give them porphyria or colony-stimulating factor to improve their counts, it becomes a problem. If you're giving chemotherapy to patients when you're not able to do blood work free of charge regularly to check their counts, it becomes a problem. If you're giving chemotherapy where you're not going to be able to manage the nausea, the vomiting, and the diarrhea, it becomes a problem. Where you don't have a palliative care team that can help with managing some of these symptoms, some of the pain, it becomes a problem. So that is why this could be right or wrong, but it's a notion because cancer itself is going to kill you over time. And majority of those who go into it, there are biases. There are intrinsic biases, even when you want to look at the data empirically, but we need to do studies. These are all things I will encourage medical students to do in Cameroon. But what I can tell you that it's not the training of medical oncologists that gives you the tendency to give chemotherapy right. It's not. You'll be very surprised. Where I train, it is the quality of your nurse oncologists who understand how to give these drugs because they are deadly drugs, who can give them safely, appropriately, and these patients can follow up appropriately for you to give these drugs. It's not because you have chemotherapy that you know how to give it. And if we live in an environment where we don't train nurses in oncology, we don't have subspecialty training. I'm taking oncology just as one. We don't train dosimetries. They will make a lot of mistakes. Cindy is going to tell you that. You don't have physicists in place. You think you can just run radiation. You're going to burn women. You don't have all those things in place. You're going to do a lot of harm than good. So the old addict by patients in Cameroon saying chemotherapy kills them, difficult to prove right or wrong, but the situation in place right now, there is still lack of training. Cancer and fertility and issues with prostate cancer, that can be a debate for years. Someone put it in the, by having sex multiple times, does that reduce your risk of prostate cancer? There's data out there that you see both ways, okay? There is data, if men live long, they will either have a benign prostate hypertrophy or prostate cancer. Prostate cancer is a topic I would love to present on, but not really, maybe not in the town hall, but more of an educational series like I did for breast cancer. Why? Because not all prostate patients, you could have 10 patients with prostate cancer, and I'm going to treat them in 10 different ways. There are people who have prostate cancer for 10 years and nothing's going to happen to them. There are others who have prostate cancer for 1 year, it's going to be metastatic, it's going to be aggressive, they'll die from it. So a lot still needs to be researched. There is data both ways about sexual behavior and prostate cancer, but there is data on prostate cancer prevention is one of those things that is difficult to really tell what you can do to prevent it. But early screening is available. There is a genetic factor for Africans, Ashkenazi Jews. There is the BRCA2 gene. There is nutrition. Also, there is exercise. There is also hormonal treatment and hormonal therapies that you've had prior that can predispose you. Now, when it comes to the last aspect, I just want to emphasize, as usual, that prevention is the mother of public health. I'll always call it that way. There are few other mothers than prevention. Prevention, prevention, prevention. I'm going to sing it every day. It being primary, tertiary, secondary, or even it's just one way we can go. So I'll leave it there so that we can get other questions and discuss other things.
Yeah, you made thanks a lot, Munoh, for that, and I think that's why Maloba's question is so important on the genetic marker. There's a paper, I think I shared this paper with you earlier this week, or maybe last week when it came out, that from Nature that said we should forget about calling cancers lung cancer, breast cancer, because the genetic profile of every cancer would dictate its kind of treatment. And you said something that you could have 10 prostate cancer. That's what you said, Dr. Munoh, that if you can have 10 cancer patients and actually treat all 10 of them differently. So using that genetic. So I just really wanted to applaud Maloba on that important aspect. And it's something that we haven't really come to speed with. And I really hope we will really make some progress, Maloba, in terms of expanding our capacity to genetically profile these different kinds of cancers in our context, because we don't have much information is known on that. So thanks a lot, Maloba, for bringing that up. Before I call Dr. Ojong, the next person, I just wanted to, Dr. Gobina put something in the chat, and I don't know if Dr. Gobina is still here, and we really wanted to hear him. I think he raised a very important point on how he thinks and perceives how we should transition and think about cancer screening, and the emphasis, moving the emphasis, I think, from primary prevention to secondary prevention. And Dr. Gobina, I'd like to hear more about your insights from your own practice as a nephrologist in Cameroon, and what you've seen in your practice, and what you think practical steps that we can take to resolve this. Dr. Gobina.
Yes, thank you. Thank you, guys. Thank you for this wonderful initiative. It's a joy to be with you. Yes, just to go straight to the point. So I think that in our communication within the healthcare family, we understand what secondary prevention is, tertiary prevention, but the community may not understand those two. They understand primary prevention. They know they will be asking, what should I do to not have this disease? And when it comes to cancers, do all you can. There are a lot of cancers about which there is nothing you can do. In fact, most of them, especially when we talk of all that is genetically induced, you cannot change your genes. You can struggle to control one or two risk factors, smoking and all of that. But prevention will help you maybe where you have to take a vaccine and that, but that's just a minute %. So
Wow, looks like we lost Dr. Gobina.
Yeah, did you have any comments on that?
So I would go back to Franklin Bowen's question, just to, because I think it was a question I wanted to go back to, and then I would continue about what Gobina is saying. So it's so important, as you said, Brian, that these are things I usually don't want to discuss here, because it's like being unable to build a little house and then you want to build a skyscraper, you understand? But our cancer care is moving away from just basic anatomopathological definition of things and looking at what is driving cancer genetically. I'll take, for example, lung cancer, where that's my subspecialty. I do a lot of lung cancer. You could have 20 lung cancer patients in my practice. 10 years ago, I'm going to give them with metastatic disease, I'll give them carboplatinum with pemetrexed, and I may add an immunotherapy to it called pembrolizumab or atezolizumab or durvalumab or cemiplimab. Today, I'm going to run a next generation sequencing. And this next generation sequencing is going to tell me what is driving their cancer. If their cancer is being driven by what we call an EGFR mutation, which could be the most common ones, could be one of the EGFR mutations that is common, like those who have T790M EGFR mutations, those who have, I would give them a different treatment, maybe called osimertinib. If they have EGFR mutation exon 20, I would give them a different treatment called amivantamab. If they have ARC mutations, I would give them a different treatment called alatinib, brigatinib, or lolatinib. If they have a ROS mutation, they would get a different treatment called entrectinib. If they have a RET mutation, they will get a different treatment called brigatinib. If they have NTRK mutation, the treatment is going to be different. BRAF mutation is going to be different. MET mutation is going to be different. KRAS mutation is going to be different. HER2 mutation will be different. So I'm just giving you the tip of the iceberg. That's how we treat cancers now. And that's why the training of oncologists, even back home, they need to have that. It baffles me at times that we have resources that we always want to not use or neglect. These are all things that we have to integrate in training our oncologists right now, because that's the future. So cancer is moving away from just saying, even in breast cancer, we are trying to classify them. That's why I was asking right from the beginning when I started oncology, why am I not seeing PR and ER status, hormonal status of these patients? Why am I not seeing those basic things that have been existing for 30 years? Why are we not still able to do it in Cameroon? So I will go back to our basis. We need to reinforce our basis. After reinforcing our basis, we can come to NGS. COVID gave us a lot of tools that we can use. We are working towards that. We can find a day sometime next year in the town hall and talk about the future and how we can do things. But trust me, the future is amazing. I have this discussion with Brian all the time. The future in oncology is so amazing that oncology is light years away from other specialties, including cardiology, every other specialty in medicine. Light years when it comes to personalized medicine. We are light years away from the rest. And I think that is how the others will catch up. So, Brian, going back to, I don't know if Gobinar is back.
Gobinar is here. Yeah.
Yes, let him continue, please.
Yeah, sorry, guys. Each time lockdown is announced, network goes haywire. I suspect that they are listening on the calls around this time. So it's horrible right now. Yeah, so I was talking about the message which the community needs to retain and have as their own catchphrase, catchword. And prevention may be difficult because for most cancers, they cannot prevent. But if they remember, and it's vulgar in on the radios, that screen for cancers and treat, so that they need to get warm towards early treatment. That is how you get good outcomes. And screening, endlessly do screening once you qualify. Because for most cancers, they will ask, what can I do? But they really cannot do prevention at the level of primary prevention. When you get to secondary prevention, typically you already have the healthcare workers involved. So it's no longer just what you can do alone. And so they need to really get that message. And I really loved your talk, Munoh. I think that the paper you you presented about all those resolutions and little or nothing done, I'm hoping that we're not going to have another 10 years. Something needs to be done. And if I were to ask a simple question, you mentioned some amazing drugs which are doing wonders. And I would ask, how available are those drugs in the US, in the UK, in France? And I can imagine that the availability of most of these drugs is because of insurance. I'm not saying that that's the solution for Cameroon. I don't think that's the solution for Cameroon. These drugs are expensive and will remain expensive. But what most of those societies have, which we are lagging behind in so much, that is giving them access to the best medication with a click of a finger, is clinical trials. If we don't bring clinical trials to Cameroon, we will insurance, health, universal health coverage cannot carry the burden of availability of all of these drugs, these molecules. So I would love to see teams being built up in this, our small community, to bring clinical trials to Cameroon. That's how people will get access to the latest generation molecule. We do have patients. And it's a sad thing that, you know, the trials are done in the US. Even if it's on black skin in the US, it's not the same like doing it on Cameroonian skin in Cameroon. So the field is wide and open. And when you have clinical trials come, if along with it comes resources and personnel and trainings, that builds the overall teams that we're looking for in terms of the expertise for the nurses, for the doctors. I think research and the package that comes with research is one of the great ways to improve access to care for cancer patients in Cameroon. Thank you.
Yeah, thank you. I'll just do a short reaction, and I agree totally with almost everything you have said, because as the old adage says, what can I do in order to prevent? I said it early in my talk. Age is the #1 risk factor for cancer. It's non-modifiable. At times, some sex, being male and female, is #1 risk factor. Being breast cancer, #1 risk factor, if you do all analysis, being a woman, clearly. #2 is being as you age. #3 may be other environmental factors and all of. So at times, we cannot really totally prevent some cancers. Some of them are preventable 100%, like when you talk about cervical and others, things like we can drastically reduce lung cancer almost to 0. That's why the prevalence is very low in our settings. Now, secondary prevention is very pivotal, and we need to build strong health systems. And building a strong and robust health system does not mean technology itself. It means multiple little things in the health system in place. If I'm leaving to go start a clinical trial in Cameroon, what are the bottlenecks? What is even the availability of the training of those who are available to run a good clinical trial? Those who are in the town hall who mark here every day, you know that I tried to bring a trial in Cameroon, and the ministry confirmed it, of almost more than $10 million trial during COVID. We could not do it. We just could not do it. I did everything possible in the US. Then, with Dr. Boguma, we had a lot of insights into big companies here. She was magnificent. They could not do it. Now, how do we even build our resources in such a way that we're going to be ready for that? I am an oncologist. I run all the clinic. I am in charge of all the long clinical trials in our practice. And I can tell you, in the whole of the NCI, the NIH, 80% of all trials in medicine, in all of medicine, including surgery, whatever you talk about, is in oncology, 80%. We have so many trials and we're looking for patients. Now they're looking for diversity. So I support Dr. Gobina very strongly. If we can do that, build our resources, and Elvis has a strong project, the Dakar project going on to build resources, and those things will help in Cameroon. Let me stop here so research, insurance, universal insurance is a big topic on its own, trying to cover care. And there was a question Gobina asked me, how available these drugs are. Let me tell you, the strange thing in the US is that my patients get the drug the next day after it is approved.
Yeah.
I even get it for them before it is approved. So I have patients, I'm so excited. Maybe others may think oncology is a sad specialty. If you know it, it's such an amazing specialty. I talk with Sydney all the time. I'm so excited that I have a patient who is on osimertinib and progressing. 2 days ago after ASCO, it came out that losartanib with amivantamab can improve him. I didn't have an approval, and I placed him the next day on that drug. Next day. And that is how amazing accessibility is. So I know time is running out, so I want to give time.
So
for
maybe
the others.
before Elvis, I just really wonder the next people coming up. I know Ojong, I see Ashu, and Sydney is there. Really keep it brief, straight to the point, so that we can hit the target.
Yeah.
Yes, hi Dr. Munoh, and hi everybody. Thank you for that brilliant talk. Yes, I think I'm gonna kind of piggyback to one thing Dr. Munoh said, and I think also Dr. Gobina said about back to basics. When we find ourselves in a low resource setting like Cameroon, our goal is practical solutions that can help that grandma, that 24-year-old lady, or that grandpa today. And when Dr. Gobina was asking about something that you can tell that woman today that will make a difference, I'll give you an example. Just tell her that breast cancer, which is one of the most prevalent cancers in Cameroon, it is very curable. Right there, breast cancer has a 98% survival of 5 years if you detect early. Once you tell people that, hey, if you find this cancer, you can actually cure it, then they start listening to you. The worst thing is for somebody to lose hope when they feel like, oh, there's no point for me to get screened, to get diagnosed if I'm not going to get treated. Let's focus on these low-hanging fruits. There's nothing that's going to make a bigger difference in cervical cancer than the vaccine. There's nothing that's going to make a bigger difference in breast cancer than early screening mammography. There's nothing that's going to make a bigger difference in lung cancer than smoking cessation. Okay, these are some messages that they are short, they are brief, and they're going to make an impact right now. When I gave my talk a few weeks ago, I did give quite a few things that people can implement today, because at the end of the day, that's what we want. Here in America, we are privileged to have all these monoclonal antibodies and all kinds of immunotherapy that we know it's not going to be available in Cameroon anytime soon. But for the little people, the person down on the street that want a practical solution, let us be there for them and tell them that get screened. If you're a woman above 35, start getting screened today, because if you're diagnosed early, you have a 98% chance of survival. One little thing that is not talked about a lot in Cameroon, and I think that can make a big difference, is personal risk. And what I mean by that, like genetic aspects of it. You meet people who come in with certain symptoms, and maybe their father died 10 years ago, or mom died 10 years ago, and they have no clue what killed them. Okay, if you know that you have a family member who was diagnosed with cancer, or there's anybody in your family, then that puts you at an elevated risk. So now you want to start screening. When you make people to know that it's very close to home, then they start paying attention. So I think we need to, when patients come in with those conditions, find out if they have any predispositions, any family history of cancers that would make them to listen. Hey, grandpa died of lung cancer, grandma died of breast cancer. You can make a difference in your life today if you start getting screened. Let us focus on those practical solutions, and we are actually going to make a difference today.
Yeah, thank you, Sydney. Thanks for the work you're doing in Cameroon. You're one of the pillars that is showing example, and you've just summarized it better. Cancers are 200 different diseases. We need to emphasize on the most common ones and create messages directed towards those common cancers. Start by there and move forward. And as you said, here in the US, really, because of screening, I turn not to see stage 4 breast cancer all the time. 80% of those who work into my office are going to be cured. In the next 10 years, they're not going to be bothered. Now, when we get to that point in Cameroon where we start screening, as you're doing in your center already, and we get to a point where we start training pathologists to give us the right information that we need, and then we get to a point where we start training surgeons to do the right surgery based on pathology now that is available, we're going to make people happy, and we're going to move things forward. So I think moving forward is just the best thing. I'll leave it there, and you really summarized it very well. We had a lot of discussion that we had to do in this town hall concerning a case, which I presented it briefly in one of my introductory presentations, but I would allow the others to have questions. And if I can beg the moderators to give us an additional 15 minutes, that would be nice.
Yeah, we're really running. I really want to hear Dr. Ojang's remarks, but there's something that in one aspect of Dr. Gobina's question that I think you didn't really answer. And I know, as in your position as an oncologist, how can we expand clinical trials availability? I think Gobina talked about the fact that most cancer clinical trials or drug trials are primarily being done in high-income countries, and we have there's limited participation, of African countries. So how can we? And I think it presents a very significant gap in terms of genetic pool, genetic profiling for this therapeutic target. So in your role, and people mention in the chat the importance of networking, and I totally agree, but I really want to know practically, how can we fix this?
Yeah, I'll be frank to you, Brian. Most of the time, clinical trials in oncology are driven by pharmaceutical companies. And they drive trials based on where the market is.
Money. Yep,
You're not
absolutely.
going to drive trial to a place where the people will not be able to afford your drugs. You will not spend $1 billion for a drug that no one is going to be able to buy. So you want to target the population which is going to buy your drugs. Then you need regulations. Now that the the NIH has certain regulations for trials to even be appropriate, even in the US. I'll tell you something. All the prostate trials in the US, we know that prostate cancer affects Black people more. They have more severe disease. Do you know the population of Blacks that were included? Less than 5% in all the trials in the US and Europe. How do you generalize it to a Black population? I'm a Black guy and I get so biased over that and I get pissed. They know me in my office. We're coming for a trial. I always do subgroup analysis and I ask those questions and everybody's, because I'm the only Black guy in the room. Where I am, there are a few Blacks and everybody's like, oh, Kenne's hand is up again. It's going to be one of those Black questions. Question is, you do have multiple myeloma. We know that Blacks have more multiple myeloma and their disease is different. How many people in Cameroon have been diagnosed with multiple myeloma? Few, because nobody thinks about it. There are many cases of multiple myeloma like that in Cameroon. It's genetic, it's Blacks. Nobody diagnoses it. The reason is because, and the trials, Black population is less than 5%. Still, all those trials, all the big trials you can quote. What is the problem? The problem is an intrinsic problem where the pharma company knows Blacks are poor. And they know that those populations are not going to buy their drugs. So they are targeting people who can buy their drugs. But how do we move forward? We need to create organizations that are going to advocate for this universal research coverage. We need to have African countries themselves come together and advocate for themselves how they did with HIV. We need to lobby. We need good lobbyists that we're going to lobby and sit on the table. Where if you want to take yourself out of the table, you're never going to be included. We are going to need to get government regulations that exist now that tells you that if your trial does not have minority population 5%, we are not going to publish it. We are not even going to accept the results. Those are things that we need to come together. As Africa, as a single country, we cannot come together as one. We need to come together as a whole group. HIV can teach us a lesson about this. We need to also revolt against some of these companies and get to produce our essential drugs and be able to be self-sufficient. If we are not self-sufficient and we rely on others, you will never become the priority or on the table. I always take sickle cell, for example. The hydroxyurea clinical trials were done in the US in 1988. Do you know when they were done in Africa? In 2018. It took over 30 years to get them done in Africa, 20 years. And where is sickle cell found in the world? In Africa. Is there any African country with a sickle cell policy other than Ghana? No. Where are we moving towards? If we ourselves do not appreciate that we have a problem, no one is going to appreciate it for you. Nobody is going to be a town crier at your death and cry more than you who have lost your father. You need to be able to cry your death well and play the drums as much as you can, Brian.
Thank you. Thank you, Dr. Munoh. Dr. Ojong, please. And thanks a lot for your patience. You're muted.
I'm sorry. It's always a pleasure listening to the different contributors on the town hall. Thank you to Dr. Munoh for another very informative and enlightening presentation. I'll just chime in very fast with the contribution and then end with the request. Now, I have listened to the different contributions and I'm really amazed at the depth of them. But then again, I'm saying we seem to have a bad habit of repeating the same errors to problems. We are trying to always medicalize the solution. And I feel the way forward towards bridging the gap for cancer care in Cameroon is not medical. Hyper-medicalize the whole system, you change nothing. It's political. It's policy. And when I read I skimmed rapidly through the document you shared with us, Brian, and I see a policy document which is completely medical, and I'm like, they'll have no solutions. Because science might find all the cure, all the treatments, but only politics gets to cure the patient. But the question is, right now, if I'm the government of Cameroon, why should I put resources, and resources are not only financial, resources is even just prioritizing something on the political agenda. Why should I put cancer on the table when I have malaria, I have I have HIV, I have maternal mortality to handle, I have 1,000 other things. Even if I came to non-communicable diseases, why should I put cancer ahead of diabetes, for example? The question is, are we creating the political priority? And it brings me to my first question. What can we collectively do to have a national cancer registry in Cameroon? I personally find it's abnormal that in a country which has well-defined centers, at least for patients who are treated with cancer, we're still using estimate numbers. Centers don't collaborate. Centers don't share their data. Bingo won't give her data to Hôpital Général. Hôpital Général won't give her data to La Quintini. People hold on to data. But until you start telling the government what the data is saying, real data, you can't create priority. You can't tell the story. So how do we create that registry? I think that's a practical way forward to putting cancer on the table and saying, see, this is the depth of it. And those who don't die go to India, and those who go to India are ministers. So the poor people are dying. There's an equity issue. You start driving a political story. Then cancer becomes a real issue. But if it's about, oh, there's no MRI, there's no this, there's no that, even for doctors to be trained, the state must feel, okay, we need these doctors. Where's the data that shows that we need them? We're talking about estimates in 2023. We need to move in that direction. And then my plea, so that I don't monopolize the floor, my plea is, there is a fellowship call going on. It's out there by the Society for Immunotherapy in Cancer in the US. I think it's in Milwaukee, something like that. Unfortunately, and I'm pricking Katia, who is on the call, most times when our academia see fellowship calls, I'll tell you what they see. They see an opportunity to have extra 10,000, extra 5. It doesn't operate that way. How can we leverage what some of us know and what some of us can do with the brilliant colleagues we have down to ensure this kind of north to south collaboration on such opportunities? And you realize that we'll come right back down to the policy circle. But we need to push our science here at the front of such collaborations if we want to drive change in fields like cancer, which for now are clearly not a priority, however much we talk about them. That was my little contribution. So thank you.
Yeah, so thank you, Dr. Ojong, for always having a brilliant insight into policy and the way things are done, how we can do practical. I totally agree with you. Now, I've always said there are times you need to hit the hammer on the head where it is. Those who have led oncology in Cameroon, who could set the priority, who could get research done, and who could change the agenda, have never been those who are forthcoming with that kind of data. Brian and I took the whole week trying to find data in Cameroon concerning cancer. It was so amazing how difficult it is to actually get data, but you get people who are sick all the time. So how do you prioritize something when you don't even have data to back it up? We do have private hospital-based registries, but Cameroon needs cancer in-hospital registries that can communicate, and also needs community registries, cancer registries. And policy is a big problem, and we need to prioritize it. We need people who are going to be advocates for that. And going to training, which is the last thing you said, there is nothing as good as people being able to access knowledge. My weakness in Cameroon has always been, even when you provide knowledge for free, we did do a seminar on breast cancer, but it actually gets to a point where I don't even know if those who are back home do want that kind of knowledge. Because if they do appreciate it, they're going to share it. It's free of charge. Maybe at times when things are free, people don't give value to it. People give value to when they get white people to come back home who have People that I talk to and they listen to me, they go back home and they give discussions. It's full, the whole amphitheater is full. But when it's coming from people like yourself, we as Blacks, we have always had this aspect of not taking information from people we know and preferring from people who don't know, whom we don't know, who are our assistants, even here abroad. It's sad, but I have to say, I go to all these international conferences that are providing knowledge. Some of those who are presenting cannot even present where I present. But because it's Africa, they are going to go present to Africans, and everyone wants to rush to those seminars. It's sad, but our mentality is a big problem. Our mentality is a big strive to preventing us from growing. And Cindy is going to tell you, one of the biggest physicists in America is even a Cameroonian. There are many of them who change data, who change the way things are. I'm not sure Cameroon can even listen to them, but they'll prefer to go hire a white guy and pay him millions of dollars to come talk trash to them. It may be good knowledge, but I'm just saying this, I'm putting this out there, that valorizing our own is a big problem. That's one of my goals in the town hall, that everyone who is a Cameroonian who is able to change things, provide knowledge, we need to share it and make sure people come in and listen. And also go back home and make change and try to change policy also. I will leave it there.
Thank you, Munoh. Then I think we'll take the last question from Rebang Ashu. Rebang, please.
Hi, everyone. Thank you, Dr. Munoh, for this insightful presentation on cancer. I think personally, it's actually very, I don't know, I took it very serious because maybe I've invested so much time on HIV and maybe cancer now. It's a whole new picture to me, even though it's not that new. I'm so happy because you said something in regards to the incidence. Like, we have a low incidence, not because we actually are not because we're a low disease country in terms of cancer, but maybe it's because of underdiagnosing and all of that. So I'm actually happy to be able to actually appreciate that particular fact. You said a couple of words that I took notice of. You said you used the word holistic, which I'm going to use maybe at the end of my question or my contribution. But what is more catching is the aspect of sensitization. And I will use maybe cervical cancer cervical cancer per se as a point of contact. And we spoke not about sensitization and screening as part of the main preventive measures towards ending cancer or controlling cancer in Cameroon. But my question is, you spoke about policies being a bit not specified or not rigid or not well implemented. Yes, all of us can see that. So what is the situation right now as per the communication strategies in Cameroon as far as, or sensitization as far as cancer is concerned, let's say cervical cancer? Because if there is actually what's happening at the level of our routine ANC for women that we are trying to reach as far as cancer is concerned, I'll use HIV as a point of contact. With all the tremendous work that's been done towards HIV, we can see that that could be a route for us to follow. Our education system, we have our target population in that light, especially girls of childbearing age. How are they being reached in terms of sensitization and communication, and maybe parastatal cooperatives? For example, in the birth of HIV, we used to have organizations like CDC, the plantation farming, where they had a very deep or very strict measure in terms of HIV screening and all of that. So if we are going back to the firewood days and reminding our mothers that firewood and all of these things are predisposing factors to cancer, what are we using as communication challenges? Because therefore we understand that the problem is deeply rooted in the most underdeserving, in quotes, Cameroonian, the very poor people. So just a few suggestions maybe for me, that if we are going to use the word holistic, as you said, use a very beautiful word, in your effort to create that strong clinical team for combating cancer in the most clinical way, let's not forget to add maybe our traditional rulers, our religious rulers. I mean, we have to go back to the basics, to the roots of the whole thing in terms of communication. And what are the communication channels that we have available for the 9 to 10 years to 15 years are available in terms of cancer sensitization? And I think that's how holistic of an approach we have to use in terms of combating cancer. Let me be specific, maybe cervical cancer, in terms of those who are getting affected. And at the end of the day, you know, communication, personally, I am a great beneficiary of, or be a great beneficiary of this communication improvement for behavioral change, because as concerns the cancer, I'm still very maybe bad with it, maybe good with HIV, but cancer is something that is going to help us, because the way HIV has been, maybe looking at cancer as not a problem or not a serious public health crisis in Cameroon, as others may say, but it's just coming in. It's just coming behind, I'll put it like that. So maybe we learn from our strategies as far as HIV was concerned, then put into cancer. Thank you.
Thank you.
Brief. I'll try to be brief so that we can finish on time. So I think I'm not a communication specialist, and I saw Dr. Akko was here, which I would have loved to hear what they're doing in terms of this in Cameroon, but I always don't want to belittle everything that Cameroon does. Cameroon has been a great nation in certain things. In 2010, when I went to Ghana, the Cameroon model on HIV communication was being taught throughout Africa. And there was teaching on how 5% Jeune was created and the impact it had on HIV and the use of condoms. And in Cameroon, my final thesis, which my classmates, if they are here, they all attended with a lot of interest because I was talking about sexuality. At the time, I was investigating the knowledge, attitude, and practice of sexual behaviors of university students when it comes to do with HIV. And I found out that knowledge itself was almost 99%, but implementation and use of condom became a problem, which knowledge, attitude, and practice is something that you need to understand the psychosocial environment and the people. So now, going back to your questions, using HIV as a tool, as a model, there is a lot we need to do. We need to understand traditionally what happened with vaccines in Cameroon. We need to understand and acknowledge the different mishaps that may have happened in the world, in Cameroon, miscommunications. We need to learn to know, as if Dr. Ferdinand is here, who are the gatekeepers? I can still recall, even more than 2 years ago, who are the true gatekeepers of the community? We need to involve them. Are they traditional rulers? Is it just this one power with a wine tapper? All those people need to be involved in any policy and anytime you're making a strategy. So I will not talk about what Cameroon is doing, but I know Cameroon has always done a great job when it comes to try as much as possible to communicate, but there is much still to be done. And I would think that communication experts need to be used, especially in preventable cancers, which are primary preventable cancers, such as cervical cancer. We need a lot of teaching. We're targeting a very vulnerable population, young girls who are fertile and boys, so there could be multiple rumors that even occur in developed countries, including the US and Europe, which actually makes people not want to take these vaccines. We need to be able to target them with the right message. In Cameroon, I know the last campaigns, they used prominent women. All the prominent women were made a statement, they were put in posters. They used several strategies, which I think we need to evaluate how effective those strategies were. Now I'm going to go to the aspect of the firewood kitchen for our mothers. You cannot tell someone, I'm just using this as an example, you cannot tell someone to stop doing something when you don't have a solution. If you don't have a solution for them, which is practical, cheap, and that's where we need our engineers, we need those who are going to create solutions on how they should be able to cook food and provide little risk, not just telling them that there is risk. Each time I'm always practical. Don't come tell me that this is a problem when you don't have a solution for it. Telling me that there's a problem without a solution simply makes me look at you like just trying to make my anxiety go up. So you should be able to provide solutions when you're able to talk about problems. Now, holistic is a word I use very frequently. And I'll tell you how my cancer center works in the US. In my cancer center in the US, I do have all the primary care doctors that see patients who have a mass. Having a mass does not mean you have cancer. And they tell me, oh, I have this patient who has a mass. I say, no tissue, no issue. Then they call my nurse navigator, who is a navigator for lung cancer, is going to see that tissue and say, okay, let me send him back to see a cardiothoracic surgeon, and let's see, or interventional radiologist, let's see if we can biopsy it. They're going to get the social workers involved, who are going to evaluate this patient socially. How is his financial state? Is he able to afford all these things? They would get those psychiatrists in the community get involved to see how is he taking this diagnosis. Then he's going to get a biopsy, come to see me. I would send him back maybe to see if I see that he's elderly, unable to sustain any treatment, to see Sydney and the others in their team. They will look at him then and tell me, we'll communicate and say what we can do together. We would have a tumor board where we'll invite the pulmonologists, we'll invite everyone who's going to come in, the psychosocial workers, we'll invite the social workers, and we'll be able to talk about this patient's financial status, what treatment is better, what is not going to cause him to be handicapped, how much survivor can I provide him as an oncologist, as a radiation oncologist. That is holistic management. So I'm just summarizing this as holistic, Brian, and over. I think we're done. Okay.
Yeah, I think your passion and your enthusiasm for this subject really bleeds through when you talk about it, and we really see the dedication there. And I also want to thank the audience for all your insightful and thoughtful comments and additions that have been made. So thanks a lot. We have since the year began, we've decided to create a policy briefing from all the conversations that we've been having, and we will be uploading this as a PDF document on the Cameroon Town Hall website, which is currently under development. So you will be able to find a good, concise policy briefing that has come out of this discussion. With that said, I will hand over the presentation to Elvis, who will continue with the moderation, and then we'll eventually close. And also, I want to mention that there's a town hall after this, and Dr. Joshua Tambe, I think he put a last question in the chat, which might not be appropriate to discuss here on the recording, but hopefully we'll be able to talk about it during the parking lot session. So I'm looking forward to that. Over to you, Elvis.
Thank you, Brian. And the moderator is Kate today, so I'll be handing over to him to close the session. It's been really a great session. I just want to thank everyone for coming, and to say that I like us to look this presentation like, just an eye-opener, right? It's not to make us feel depressed that we have a lot to do, but it's just an eye-opener that we can do a lot as well. We can do a lot. That's what Munoh wants to drive across, that we can do a lot. And the little steps that we all take individually, collectively as a group, can enhance the care for cancer patients in Cameroon. Efforts like the one Sydney has, a clear radiology in the Southwest, can offer some diagnostic tool to patients in the Southwest. That's a really great effort by diaspora. And we launched a Give Back project. We hope that part of your Give Back project will be to carry out either just a community health education programs on cervical cancer or breast cancer in your village, in your community. These are just little steps that can make an impact in the life of people. I think if change is not about changing the entire country all at once, if you can change the life of just people in your neighborhood to think about breast cancer, cervical cancer, prostate cancer, that's just the kind of change we're talking about. So I really want to thank everyone for attending the session, and hopefully we continue to be here in a fortnight for yet another very exciting session. Over to you, Kate.
Yeah, thank you so much, Elvis. Thank you so much again, Munoh, for the presentation. Brilliant presentation, brilliant Q&A session from Brian, and brilliant discussions, questions coming from everybody who has attended the town hall this particular evening. And I'm going to end with 2 words. We talked a lot about prevention, and it seems Munoh ended with holistic. So prevention can also be holistic. Holistic prevention, coupling together primordial prevention that has to do with policies and everything Ojong was talking about. How do we conceive our country, and how do we conceive and drive development? How do we drive policies? Then we can trickle down to primary, and then to secondary with screening, and even tertiary. So prevention can also be holistic. So thank you so much for joining the town hall this wonderful evening. and catch you again in a fortnight with another beautiful discussion.